Okay, the final presentation will be by Dr. Steve Johnston from the Royal Marsden Hospital. Title of his talk is Treatment of ER-positive, HER2-positive breast cancer. Steve?
Thank you, Carlos, and the organizers for inviting me to talk about the treatment of ER-positive, HER2-positive breast cancer. These are my disclosures. So we've heard about these two pathways, estrogen receptor signaling, HER2 signaling, and how they crosstalk with each other. And we've also heard that if we block one of the pathways, HER2, what happens is estrogen receptor upregulates and mitigates and reduces the effectiveness of the HER2 blockade. So it makes logical sense that if we're going to think of how treating this subgroup of breast cancers, we should combine therapies that target both hormone receptors and the HER2 signaling pathway. So in terms of treatment, I'm going to briefly look at metastatic breast cancer, how we've looked at combined HER2 and endocrine therapies, and potentially now we're looking at triple-based combinations. I'll talk a little bit about neoadjuvant and adjuvant therapy, because we know PCR rates are very different in these subgroups. What does that mean, and what are our options in the adjuvant and extended adjuvant therapy setting? And I'll briefly at the end give my insights into the evolving biology of HER2, which is plastic and which changes in relation to endocrine resistance. Now, I'm very glad Rachel showed this slide as well. I was doing my PhD on endocrine resistance in Mitch Dowsett's lab nearly 30 years ago, and I was struck by the simplicity and brilliance of this simple experiment which Rachel took you through. Acquired expression to hormone receptor to endocrine therapy is an upregulation of HER2, and if you overexpress HER2, you're resistant to treatment. But this observation was light years before the clinical translation of this happened in studies. 10 years after that, there was some early work looking in metastatic disease that responses to endocrine therapy were lower if the tumors were HER2 positive compared to HER2 negative. But it was another 8 or 10 years before 3 studies started to address this in a randomized fashion. Here are the studies that looked at mono HER2 blockade with trastuzumab and endocrine therapy versus endocrine therapy alone. And what you can see consistently is that the response rates to endocrine therapy alone, if tumors express HER2, is very low, median PFS of around about 3 months. And you can modestly increment on that between 5 and 8 months with the addition of HER2 therapy. But proper HER2 therapy now involves dual blockade. So these 2 studies looked at the dual combinations of either pertuzumab and trastuzumab with an AI versus trastuzumab and an AI in the PATAIN study, or in the alternative study looking at lapatinib, trastuzumab and an AI versus either alone with an AI. They were slightly different. PATAIN used patients that had induction chemotherapy, whereas alternative didn't, and alternative required patients to have all had prior trastuzumab. But in terms of the results, again, similar observations were seen. If we look at the alternative study on the right, you can see that dual blockade with HER2 therapy was better than monoblockade with HER2 therapy in addition to an AI. Those patients were no prior chemotherapy, so it was a first-line setting, so the response rates were relatively modest, but all patients had prior trastuzumab. Whereas the PATAIN study perhaps looks more like real life, where patients had had induction chemotherapy and then went on to maintenance settings, where dual antibody with endocrine therapy was better than single agent antibody therapy in endocrine treatment. Now, I think it's important to recognize that the prognosis of patients with ER-positive, HER2-positive breast cancers in the metastatic setting is actually very good. I like this study from the Dutch Real Cancer World data set that has shown that, again, if you look in the dotted black line, these are the ER-positive, HER2-positive patients. They have a much better prognosis than those that are ER-positive, HER2-negative, and a better prognosis than the HER2-positive, ER-negative patients. So why is this? The very strong likelihood is that these patients who were receiving trastuzumab following chemotherapy were also concurrently receiving endocrine therapy. So by default, they were having combined treatment, and that almost certainly accounts for their better outcome. Now, in metastatic disease, hormone-positive metastatic disease, the world's been transformed by the introduction of CDK4/6 inhibitors. But I take you back to some of the seminal data from Rich Frinn and Dennis Slayman's group, which showed that the subgroups that really respond to CDK inhibitors are not only the luminal cells, but also the HER2-amplified breast cancer cells. So studies that have looked at combinations have started to be done. We were involved in the Monarch-HER study, which Sarah Toloni published a couple of years ago now, looking at the triplet combination of abemaciclib plus trastuzumab with or without fulvestrant in ER-positive, HER2-positive breast cancer, compared to treatment of physician's choice with HER2 therapy and chemotherapy. These were heavily pre-treated patients who'd had prior taxane therapy and prior TDM1. But there was a progression-free survival benefit for the triplet combination compared to further chemotherapy and HER2-targeted treatment. And Fabrice André presented at the ESMO meeting in Paris a few months ago that this translated into a numerical overall survival benefit. So we don't have to continue to use targeted therapy with chemotherapy. We can revert back to targeted combinations with endocrine therapy. And this needs to be explored further, so the PATINA study is really important because this is taking this observation into the first-line setting where patients after induction of chemotherapy will have dual antibody therapy with endocrine treatment plus or minus a CDK inhibitor. And this might define a new standard of care in the metastatic setting. So what are my take-home messages for metastatic disease? Well, Cleopatra remains the standard of care regimen for most patients. And in clinical practice, endocrine therapy is added to dual antibody treatment in the maintenance setting, accounting for the good outcome. But targeting of HER2, dual targeting with endocrine therapy, is an option for some patients with low-volume indolent disease. So it's important to bear that in mind. The second and third line setting is now dominated by the antibody drug conjugates, as we've seen. But these are not given with endocrine therapy. And whether that's a mistake or not, I think further research needs to go into. And non-triple combinations are coming, non-chemo triplet combinations are being explored. So briefly, let's look at neoadjuvant and adjuvant therapy. And we've known for some time that there are differences in PCR rates between ER-positive, HER2-positive, and ER-negative, HER2-positive patients. You can see in the original NeoSphere and NeoAlta studies that this was demonstrated very clearly. And a lot of people thought that means there's a different biology. If you look at the additional studies, CLGB, NSABP, Trifena, and TRAIN, they all show the same thing, much lower PCR rates. But it's important to point out that in these patients with ER-positive, HER2-positive disease, endocrine therapy was not given concurrently with neoadjuvant treatment in these trials. So perhaps they were receiving suboptimal treatment. Now, we worry if patients do not achieve a PCR. And obviously, the Cortazar paper from the Lancet demonstrated this very clearly, that if you don't achieve a PCR, you have a worse prognosis than if you do. But I don't think you probably appreciate the differences in the two subsets of HER2-positive disease, namely the hormone-positive subset in the middle and the hormone-negative subset on the left. Just look at the red curves for non-PCR, and you'll see that in the hormone-positive, HER2-positive, you have a doubling of the median event-free survival compared to the ER-negative subgroup. And why is this? Adjuvant endocrine therapy is added in this setting, and that crosstalk between endocrine therapy and HER2 therapy accounts for that better outcome. Now, in the neoadjuvant space, Kent Osborne's group, Morawami, have looked at non-chemo HER2 targeting with endocrine therapy, and this particular study looked at duration of therapy, lapatinib and trastuzumab with or without endocrine therapy for either 12 or 24 weeks. And it's a nice study because it demonstrates that if you use a non-chemotherapy option, you have to be patient. You have to wait because the responses increase over time. But looking there, you can see that the PCR rate of 24 weeks of 33% is actually better than the PCR rate for HER2-targeted treatment in the ER-negative patients. So the correct combination of drugs in the correct duration of therapy can achieve PCRs in this setting. In the adjuvant setting, just like in metastatic disease, we know that those patients have a better prognosis. These are the data from the original Herceptin studies showing the better outcome for hormone-positive compared to hormone-negative disease. But there is equal benefit from the addition of trastuzumab in terms of disease-free survival and overall survival for the addition of HER2-targeted treatment. But in the adjuvant setting, I think Ian Smith asked the question, do you need to treat for longer? Well, perhaps you do, and this is where the extranet study is really important. This looked at the addition after a completion of a year of treatment of the tyrosine kinase inhibitor neratinib and showed a positive result. And on the right-hand side, in hormone receptor negative patients, you can see that the curves separate but then come together. But on the left-hand side, you can see that in the hormone receptor positive groups, the curves separate, stay apart, and perhaps even continue to go apart. But equally, that the prognosis for those patients who aren't receiving further HER2 therapy is actually slightly worse than those who are hormone receptor negative because of that incremental year-on-year ongoing risk. So I think this tells us that we perhaps need to give longer combined therapy for HER2 hormone-positive breast cancers to get the maximum out of the treatment. So take-home message is in early breast cancer neoadjuvant therapy, we're still going to use chemotherapy for the vast majority of patients. The lower PCR rates are not a problem because endocrine therapy and the adjuvant therapy improves the outcome. And for some patients, combined HER2 therapy and endocrine treatment is an alternative option, but you have to wait. And in the adjuvant setting, we combine our endocrine therapies already. That improves the outcome. Perhaps we need to do it for longer. So the final few seconds are to just talk a little bit about my take on the evolving biology. I'm grateful to Alex Pratt for this slide that really illustrates very nicely the evolution of HER2 biology between the primary tumor and the metastasis, with a tripling in the increase of HER2-enriched cancers. Now, I'm reminded again of going back to some of Kent's original works, and this is Carolina and Kent's paper back in JCO nearly 20 years ago, where they demonstrated very nicely in simple studies looking at biopsies before and after tamoxifen that HER2 is upregulated in 10% of those that are originally HER2 negative. Some of them are FISH positive, some of them are FISH negative. And that was again way before the concept of HER2 low that we've been talking about today. So we know that the vast majority of HER2 low tumors are hormone receptor positive. And the acquisition of HER2, as we heard earlier on, is a dynamic phenomenon. And it accounts for resistance, and it's something we're increasingly going to have to measure in our metastatic patients. But it's not just HER2 low. We also now have to think about HER2 mutations. These data come from the UK Plasma Match study, where in hormone-positive breast cancers, ESR1 and PIK3CA mutations are common, but HER2 mutations occur in 6 to 12%. And it can account for, again, sensitivity to a tyrosine kinase inhibitor, which in the SUMMIT trial has been demonstrated either for neratinib monotherapy, combinations with fulvestrant, or a triplet combination with trastuzumab. So HER2 mutations are something we also need to take into account. So to conclude, in metastatic disease, yes, non-chemotherapy combinations exist, but their role is mainly in the maintenance setting. Triple combinations are being evaluated. In the early breast cancer space, maximal PCR rates are still achieved with chemotherapy, but those who don't achieve a PCR that are hormone positive benefit from adjuvant endocrine therapy, and extended therapy is something we should consider in some patients. And as far as the biology is concerned, we need to rebiopsy, we need to look at the evolving biology because HER2 is a driver, and that's something that we need to think about in our smart combinations for patients, particularly with metastatic disease. I'm grateful to colleagues who shared slides for the preparation of this talk. And on behalf of my colleagues from the Royal Marsden, where I did my PhD in endocrine resistance with Mitch Dowsett and had the early collaborations with Kent and Rachel, I'm very grateful for all the leadership, Kent, you have shown, and the inspiration, as well as the insights into the biology of the disease, which, as I say, have come long before the clinical implications have been translated. Thank you.
Thank you very much. Microphone number 3, please.
Yeah, so my question is with respect to adjuvant therapy in HER2 positive breast cancer patients who are HR positive also, whether to go with tamoxifen or do ovarian suppression and go with aromatase inhibitors with respect to the achievement of pathological CR versus non-pathological CR. So how aggressive do we need to go with hormone therapy in the adjuvant setting for HER2 positive, HR positive patients who achieve pathological CR versus who do not achieve pathological CR?
I think you just need to make what you feel is the most appropriate clinical decision for those patients based on their level of risk. Yes, if they achieve a PCR with HER2 therapy and they're hormone receptor positive, I think you would give them the appropriate adjuvant endocrine therapy dependent on whether they're pre or postmenopausal. Soft and text data were primarily in hormone-positive, HER2-negative patients, so we don't have the same level of data set to look at that. But so I think you would make clinical decisions appropriate to your patient.
Microphone number 1.
Well, actually, my question echoes the first question about role of OFS in premenopausal triple positive patients without achievement of PCR. Thank you.
I think, yes, you would still give it because they're at an increased risk.
All right. Well, thank you, Steve, very much. And this should, thank you
very much.
This should complete our symposium. Thank you for being here. Congratulations again to Dr. Osborne. Best wishes in your research moving forward.